y les quiero presentar al doctor Vincent Cottin. Por ahí los reumatólogos lo conocen un poco menos, para los neumonólogos es una figura muy conocida. Él es el director del grupo de enfermedades huérfanas que funciona en la Universidad de Lyon y es uno de los líderes de la pequeña élite de enfermedades intersticiales europea, que viene a querer decir mundial, porque son quienes más trabajan por lejos en enfermedad intersticial. Sobre todo en los últimos años, porque él siempre se ha dedicado mayoritariamente a enfermedades del tejido conectivo, con enfermedades intersticiales asociadas o enfermedades autoinmunes, y bueno, en la medida en que han aparecido nuevas opciones terapéuticas, el doctor Cottin se hizo más famoso y ahora es la rockstar en este momento de la enfermedad intersticial internacional. Así que le hemos pedido que aborde un tema que él, sobre el cual ha escrito en un par de publicaciones, sobre todo en el RJ, y que es sobre una enfermedad que vemos con mucha frecuencia y que seguramente nos pasamos por alto todavía más frecuentemente, que es la neumonía eosinofílica crónica. Así que con ustedes, el doctor Vincent Cottin.
Muchísimas gracias, Silvia, por la presentación. Y no voy a hablar en español por la presentación, pero muchísimas gracias por la invitación. Therefore, I will speak about the chronic eosinophilic pneumonia, which is a very important domain in orphan lung disease, and especially in eosinophilic lung disease, but in which there has been probably less progress than in EGPA, which was beautifully presented by Dr. Dubinsky. These are my disclosures. Eosinophilic pneumonia is can present several ways, and there are three main clinical and radiological presentations. The first one is the so-called Luffler Syndrome, which is famous but not so frequently seen because it is a very transient manifestation. It is characterized by cough, dyspnea, some wheezing, very often fever. And if you do a chest radiograph, you see some transient pulmonary infiltrates, or chest CT, of course, with pulmonary blood eosinophilia, but this all disappears after a few days, even without any treatment. So this is something that we mostly see in parasitic disease. The second one is chronic eosinophilic pneumonia, and that will be the focus of this presentation today. And a third one, which is more differential for today, is the acute eosinophilic pneumonia. And in all these conditions, the eosinophilia is defined as a peripheral blood count greater than 1 million per liter. We use the international unit, but this is equivalent to 1,000. And this is especially true over 1.5, where there is no differential for simple eosinophilia if the count is so high. And the alveolar eosinophilia is, of course, most specific of eosinophilic pneumonia. The threshold is usually set at 25%, and it is especially important if the eosinophils predominate. Of course, taking the macrophages out, because macrophages are the normal cell in a BL. And there are some rare cases where a biopsy might be needed, but we really try not to do a biopsy. So different presentations, but quite similar definitions for the level of eosinophilia. And I've also put a diagram trying to show the different conditions where, with the possibility of the eosinophilic pneumonia on the left, the asthma or airflow obstruction on the right, and systemic manifestations on the lower part. There are conditions characterized mostly by eosinophilic pneumonia, and that is the case of idiopathic acute eosinophilic pneumonia. There are also conditions characterized mostly by airflow obstruction and eosinophilia. This is, of course, the asthma or the hyper-eosinophilic asthma, when the eosinophil count is really high, or the more rare bronchiolitis. And there are, of course, some conditions which share the presence of asthma, the possibility of eosinophilic pneumonia, and the systemic manifestations. And that's, of course, where we mostly think about EGPA. But there are also cases where it can be hypereosinophilic syndrome or some systemic manifestations due to parasites or in relation to drugs. And there are also some eosinophilic vasculitis which are not associated with asthma. They do exist. And finally, there are cases very frequently associating asthma manifestations and eosinophilic pneumonia. And that's where ICEP, idiopathic chronic eosinophilic pneumonia, lies, ABPA as well, which we will not cover today. So another way of evaluating or classifying these conditions is to ask these subsequent three questions. The first question is about the systemic manifestations. If there are some, we will speak about EGPA or eosinophilic vasculitis or hypereosinophilic syndrome or DRESS, if a cause can be identified. And if not, then we would separate the acute from the chronic in case of eosinophilic pneumonia. And you can see there are some acute manifestations and some are more chronic. And finally, if this is idiopathic disease, it can be acute or chronic eosinophilic pneumonia with idiopathic disease. This is another way of separating these conditions. But there are some pitfalls that I'd like to discuss, first of all, before going into the detail of the chronic eosinophilic pneumonia, because as you've seen, most of the diagnosis relies on the presence of the eosinophilia. But the eosinophilia would disappear extremely rapidly with oral corticosteroids. So it is mandatory that in case of a suspicion or in case of a pneumonia in which we suspect it could be eosinophilic pneumonia, the blood draw be done before any treatment. And of course, experienced clinicians know that, but maybe the younger ones. And the reverse is also true. That is, it is not normal to still have eosinophilia if the patient has been receiving corticosteroids for several days. I'm speaking oral corticosteroids. And in this case, we should suspect something else than just ICEP, but it could be a vasculitis or it could be hypereosinophilic syndrome. And finally, the third pitfall is that the eosinophilia may be lacking at presentations. There are conditions with eosinophilic pneumonia, but no peripheral blood eosinophilia at presentation. And this is especially the case of the idiopathic acute eosinophilic pneumonia, in which there is peripheral blood eosinophilia, but it does appear after a few days. So if you just monitor the blood count, you would see them rising after a few days. So it's a pitfall. So let's speak more in detail of ICEP. I would say ICEP for idiopathic chronic eosinophilic pneumonia, which is the so-called Carrington disease. The literature about this condition has not changed much for the clinical presentation over the past decades. It is still a very rare condition. It does represent less than 2% of registries of rare pulmonary disease, so quite rare. However, the ICEP is probably the most frequent of the eosinophilic pneumonia, at least in Europe and North America. In some countries of the world, I'm not sure for Latin America, but I suspect some secondary causes of eosinophilic pneumonia might be more frequent. There is female predominance, the median age is 45, and a little bit less than half the patients have a history of atopia or asthma, and just as in EGPA. But smokers are less frequent. The disease onset is more than 1 month, typically with dyspnea, cough, crackles in auscultation, some wheezing possible. And there can be fatigue, fever, and even weight loss. So there can be a very symptomatic disease, which may present a little bit acutely. However, if you really ask the patient, usually the onset of symptoms is over 1 month. And these are the images that were published by Dr. Carrington in '69. And this is after these images that we speak about the negative of the photograph, the photograph with the peripheral opacities in the lung, and the negative of the pulmonary edema. There is also some upper lobe predominance of these images. These are 3 different patients from our center. You can see that in general, these are symmetrical patterns, but sometimes it's asymmetrical, but they usually predominate in the upper lobes with some peripheral predominance. But the peripheral predominance is not so typical and not so constant, let's say, as initially thought. And they can migrate even without any treatment and go from one region of the lung to another here in the lower lobe and finally here. There have been some studies of the chest CT pattern of ISEP showing that really the main feature is airspace consolidation together with ground glass opacities, and all the rest can be present, even mucus plugging, but I would suspect some of these cases might be overlapping with EBPA, because usually we see only airspace consolidation and ground glass opacities. There is, in general, an upper lobe predominance, but you can see that nearly as many patients also had a random distribution, and the peripheral distribution or predominance can be seen in this study. These are examples on the chest CT scan of patients with a typical peripheral predominance. We are looking here at the upper parts of the lung. And this is another case, or 2 other cases with different pattern, a little bit more central, but still in the upper lobes. The presence of eosinophilia, as mentioned, is key for the diagnosis. If you draw the blood before any treatment, in this condition, it is always present. And usually it's quite high, over 1,000. You can see in this series of 60 patients, the mean level of eosinophilia was 5.5. So it is usually quite high. It's not 0.6. And the range was up to 37. And in the BEL, again, doing the BEL before any treatment, the definition would be greater than 25%, but the mean value was 58%, with a range up to 95%. Usually, there is very high eosinophilia, and when there is, we know it's eosinophilic pneumonia. We don't know yet whether it is idiopathic, but we no longer need a lung biopsy. So the diagnostic criteria for ISEP are quite simple. They include a compatible imaging pattern with consolidation and air bronchogram or ground glass opacities. Second, presence of higher eosinophil count on the BEL. Here it's 40, usually we take 25. Respiratory symptoms for more than 2 to 4 weeks, and absence of another cause for the eosinophilia. And the criteria would be the same for secondary pulmonary eosinophilia, except that a cause would be identified. Because indeed, there are causes that need to be identified and need to be looked for, starting with the parasitic infection. This is a major cause of eosinophilic pneumonia worldwide, but it is more rare in some regions of the world. There are no characteristics that can help clinically to differentiate the ISEP from the parasitic origin of the eosinophilic pneumonia, except in some cases where there can be some diarrhea or some skin manifestations. But in general, the eosinophilic pneumonia is very similar. Already mentioned the Luffler syndrome. The pitfalls are that we often think before to Carrington disease and forget to look for the parasites, or we are maybe missing some knowledge in epidemiology to know which pathology is at risk in a given region of the world, or may forget to ask the patient about travel. And the diagnostic test may really vary. Some are best diagnosed with a serology, some with the stool analysis, etc. So in case of doubt, it is better to ask a specialist to make sure that we are doing the right test and not miss a possible parasitic infection. Because there are some risks, especially in the case of strongyloides, with the risk of hyperinfection when corticosteroids are given. The second cause to look for is the drugs. It sounds very simple to say that, but it's not always easy to find a cause when there is one. Again, the manifestations are usually non-specific, although there can be some skin rash, possibly in a few cases, and some severe cases may manifest as stress, but usually there are no systemic manifestations. Causality may be difficult to establish, especially because in case of eosinophilic pneumonia, most patients would receive corticosteroids, and therefore the patient would have rapid improvement despite sometimes the persistence of the drug, and then there would be a relapse. So it's sometimes in case of relapse that we suggest the diagnosis of the drug, but we should look for the drug from the first time. And for that, you probably know the Pneumotax website, which is up to date in all the causes of pulmonary or bronchus manifestations related to any drug. But in case of eosinophilic pneumonia, most of the drugs or frequent drugs involved are the non-steroid anti-inflammatory drugs, the antibiotics, and of course, a long list of others. Here are some examples. You see, in some cases, it is a little bit more reticular, but in general, you cannot really make the difference on the imaging as compared to a case with an idiopathic case of ISEP. And one other cause that is maybe less publicized is the illicit drugs, and cocaine and heroin are common cause or possible causes of eosinophilic pneumonia, especially when they are taken inhaled, but also in case of IV injection. And these are well described. Another differential to idiopathic chronic eosinophilic pneumonia is idiopathic acute eosinophilic pneumonia. And actually, the difference is quite important because the relapse rate is completely different. It's not only chronic versus acute and all the rest is the same. No, it's completely different disease, because the acute disease, in addition to have a more acute onset, is not associated with a history of asthma, but is associated to inhaled exposure, often smoking, but any other causes of inhalation can trigger the onset of this condition. This is very often a severe condition with possibility of respiratory failure. As mentioned earlier, there is usually no eosinophilia on the blood count at admission, so it's extremely easy to miss the diagnosis when the patient comes if we don't monitor the blood count after a few days. On BEL, there is a high count of eosinophilia, but there is no relapse. The main difference in my eyes as compared to the chronic disease is not the duration of the onset, it is the chest imaging, because instead of having consolidation and ground glass, we also have pleural effusion and thickening of the septa. These are three different cases of acute eosinophilic pneumonia. You see there are consolidation, there is some ground glass, but there is also a bilateral pleural effusion here, which was not related to cardiac disease, because of course you can have some heart failure in relation to EGPA, for example. Here it is an eosinophilic pleural effusion, which is not related to heart failure. And there are also signs of septal thickening, interlobular septal thickening, which are very suggestive of this diagnosis of acute eosinophilic pneumonia. In terms of treatment, treatment is quite simple because there is a response to corticosteroids, which is quite dramatic, quite spectacular. Within 48 hours, the patient would feel much better, and the chest X-ray would be back to normal within a week in a majority of the cases. The difficulty is the risk of relapse, which are present in more than half the case, which occur either after treatment discontinuation or when tapering the dose, when lowering the dose down to 5 to 10 milligrams per day of prednisone. There are not so many clinical trials, and actually I only know one about chronic eosinophilic pneumonia. That's a trial conducted in Japan where they compared a 3-month therapy to a 6-month therapy. And they randomized 55% and could compare around 20 patients per group who received 3 months versus 6 months of treatment, both of them starting at 0.5 milligrams per kilogram per day of prednisone. As you can see, all of the patients had a good response to initial treatment, and there was no significant difference in the rate of relapse. Here you have the survival curve from the cumulative relapse rate with absolutely no difference between the groups. So a short treatment is sufficient. Here it was 3 months. In our group, we even use a shorter treatment. This is our suggestion in the Ophelung group. We have 6 weeks of treatment starting 0.5 milligrams per kilo per day. And this is important for the cumulative dose because this would trigger, of course, many side effects. And for the treatment of the relapses, unfortunately, the relapses are frequent, but you have to tell the patient in advance there is this risk of relapse, but you don't need a high dose of steroids to treat the relapses. If it's ISEPT, we usually use 20 milligrams per day, total dose, for 1 month, and then taper over a total of 6 months. There has been at least 2 studies evaluating the long-term outcome of patients with ISEP. On the left, these are 2 quite old studies now from the French group showing that the rate of relapse was over half the patients. And the problem was that after a follow-up of 6 years, nearly 70% of the patients were still on steroids for asthma, and sometimes for asthma, but most of them for asthma. There was persisting airflow obstruction in a minority of them. And in a similar, well, in second of these studies, it was well described how frequent asthma is in these conditions. It is actually the vast majority of the patients with ISEP who also have asthma. What varies is the time when they have asthma. The majority or half the patients have asthma before the onset of the eosinophilic pneumonia. Some have it at the same time, and some have it following the eosinophilic pneumonia. But collectively, that's nearly 80% of the cases which have some asthma. And a more recent study from Japan compared the lung function at diagnosis, that's the left part of this pie, to the outcome, the lung function at the last evaluation, and this is the right part of this pie. And you can see even at last evaluation, there are quite a number of patients who would still have obstructive disease out of 133 cases of ISEP followed for over 6 years. 56% of them had a relapse and 32% of them had persistent pulmonary function test defects, including 20% with persistent airflow obstruction. And this persistent airflow obstruction, when it is the cause of maintaining steroids, may be targeted by a specific therapy. And this is, I think, the role of the treatments that target the IL-5 pathway. As well presented just before, there are two ways of addressing the IL-5 pathway. IL-5 is really the cytokine that drive the maturation, the differentiation, the recruitment of eosinophils, and even block apoptosis of the eosinophils. So that's really the key cytokine to stimulate eosinophils. There are at least two monoclonal antibodies, mepolizumab and rituximab, that target IL-5, and benralizumab target IL-5 receptors, which, in addition to blocking IL-5 and removing eosinophils, would cause an ADCC mechanism. But these different molecules are currently considered to have the same power to block the IL-5 pathway. In ISEP, there are no nice randomized controlled trials as in EGPA using mepolizumab, but there are a number of case reports that really show some efficacy of this drug. And there is a short series of cases showing that patients with mepolizumab would have fewer relapses, would have, of course, lower blood levels of eosinophils. And what is important for the patient, they also would receive over time less corticosteroids as compared to patients not receiving mepolizumab. These are small numbers, as you can see here, and this is not randomized, but it suggests a good efficacy of this drug, which really makes sense in terms of the mechanism of action. So should we use it? I mean, here I'm really playing the devil's advocate to see whether this is useful or not. Well, I would say yes, because IL-5 is implicated in the pathogenesis of these conditions, and it can help spare some steroids. And these patients experience frequent relapses, and as we have just seen, persistent airflow obstruction. The argument against using IL-5 targeted therapy would be that these patients respond extremely well to corticosteroids, and virtually there is no resistance to corticosteroids. The relapse can be prevented by very low doses of steroid, and we don't have many data, and this would be off-label and associated with a cost. In our group, and we've discussed that with the Reference Center for Eosinophilic Disease in France, we would see three main indications: the difficult hypereosinophilic asthma. So let's say the main indication as the indication for which mepolizumab is marketed. Frequent relapses, because patients would eventually receive a lot of steroids, and impossibility to discontinue steroids, especially if the patients have side effects. And for the last part, I will discuss briefly what to do in case of treatment failure. Well, the first thing is relapse or treatment failure. At least relapse is frequent in this condition, and I would really argue in favor of securing the diagnosis of eosinophilic pneumonia. So in case there are relapses, we have to make sure these are really relapses of eosinophilic pneumonia before embarking into a second-line therapy for that condition. And we also need to look for cause or culprit, and especially the drugs, the parasitic infections, if this has not been looked for before in that patient. And there are many causes, but in my experience, a frequent one is the use of NSAIDs, because patients have some pain, joint pain, for example, and they would use intermittently these drugs and precipitate or trigger some events of eosinophilic pneumonia. And in case we experience resistance to steroids or persistence of eosinophilia despite the steroids, I believe we should really look for another condition. This is not normal in ISEP to observe this. We should investigate for hypereosinophilic syndrome. Could it be the myeloid or the lymphotic variant? And some cases, we might consider a biopsy, and then I will exemplify this with an example. This was a case of ISEP, a 61-year-old male with a very small smoking history, presented with dyspnea, cough, and urticaria. Eosinophils in the blood were very high, 8,000, as well as in the BAL, and you can see the chest CT showing some fuzzy ground glass opacity and small consolidation. There was etiology workup performed, especially negative for drugs and parasites, and ANCAs were negative. But two things in blue were a little bit unusual. There was an extremely high level of AGE, and secondly, the patient relapsed while still on more than 10 milligrams per day of prednisone. And that was the trigger for a more specialized etiological workup, which identified abnormalities of lymphocyte phenotyping. And there was a small clone of abnormal lymphocytes, which actually made possible the diagnosis of HES, hypereosinophilic syndrome, lymphocytic variant. The patient was then treated with mepolizumab, and although part of the treatment might be similar, it is extremely important to correct the diagnosis in this case. And I'd like to draw your attention to recently described entities in the field of eosinophilia or eosinophilic pneumonia, because these are entities that are slightly overlapping ISEP or EGPA, and they escape a little bit to the usual classification that we consider in these conditions. This has been reported by the French group of eosinophilia, and they've described a dozen of patients with a systemic disease. They had clinical typical manifestations of vasculitis, and in 8 of the cases, they had histopathology demonstrating vasculitis. There was no etiology, especially HES was looked for, and there was no myeloid or lymphocytic variant. The patient had no asthma and no ANCAs. So they don't really belong to EGPA because there was no asthma, and the pattern of the vasculitis was not the same as what we see usually in EGPA, and you can look at the detail in the paper. And look here, there is a chest CT. Yes, some of these patients had eosinophilic pneumonia. And this was slightly different as compared to just ISEP or EGPA. And this is a short report of 3 patients from our group with long-limited EGPA. So what is long-limited EGPA? We speak about EGPA when there is systemic disease. Yes, but in some cases, there can be a vasculitis to the lung that is absolutely typical of EGPA. These 3 patients were followed for many years, as you can see here on the right. And eventually they had a biopsy because they had a pattern on the chest CT that was found unusual. There were ground glass, there were consolidation, but sometimes nodules. These patients had a biopsy because of a suspect nodule. And the pathology demonstrated typical patterns of EGPA with vasculitis, with eosinophilic infiltration, with granuloma, with everything, which would not correspond to just eosinophilic pneumonia as we see in Carrington disease, for example. And they had no systemic manifestation despite a duration of follow-up over 10 years. So my key messages to conclude is that first, the diagnosis of eosinophilic pneumonia mostly relies on the demonstration of alveolar eosinophilia with BALs over 25. I would really argue in favor of BAL and not only the blood count if possible, along, of course, with a suggestive chest CT pattern. The etiological workup is important to rule out the cause, the possible culprits, especially parasite, medical drugs, and illicit drugs. In many cases, corticosteroids would be highly sufficient to treat these patients. They are the mainstay of treatment. The drugs targeting IL-5 are unnecessary in the vast majority of cases. I'm speaking about the idiopathic chronic eosinophilia, but they may be useful in selected cases, especially in patients who have side effects from steroids and very frequent relapses. Any unexpected or unusual presentation or unusual outcome should prompt again the search for the persistence of a cause, especially drug or parasite, or look for rare differentials. And we've seen examples of hypereosinophilic syndrome or EGPA, sometimes EGPA localized to the lung, or eosinophilic vasculitis, and so forth. With that, thank you for your attention, and we'll be happy to participate to the discussion.
Dr. Cottin, thank you very much for that presentation. It was quite clear and comprehensive. Thank you. I think I'm safe to say that the audience did it enormously.
Thank you.
Moving on to the question segments now. Pasamos ahora a la etapa de las preguntas.
I have a question from the audience for Dr. Cottin. That is, in the case of eosinophilic pneumonia, chronic eosinophilic pneumonia, if we choose to give mepolizumab, I think that is the only IL-5 that we have in our country, how should be the duration of the treatment, and which are the parameters on which you make the decision of if continuing the treatment or that is enough and you can stop?
Well, that is a good question. In general, we would not use mepolizumab. So we would use mepolizumab, especially in patient with relapses. So the number of patients who are on steroids and we cannot reach and stop the steroids. So I think these two criteria would probably be the way of monitoring the efficacy of mepolizumab. That is, if you can stop the steroids and the patient doesn't relapse, and if you decrease significantly the frequency of the relapses, that would say that your treatment with mepolizumab is highly efficient. And then how long to maintain mepolizumab, I don't know. Well, some patients with xenophilia still have relapses 10, 15, 20 years after the initial diagnosis. I'm not saying we should continue the treatment so long, but if the patient has experienced many relapses, maybe continue for a couple of years. And then I would personally try and increase the duration between the injections and see what happens. That sometimes is a way of decreasing instead of stopping immediately a treatment.
My second question could be about Church's trial, PPA, and it's about the use of the uncertainty of the diagnosis. It's very common, especially if they are ANCA negative, not to have the certainty of the diagnosis, and so to start the treatment even with high doses of corticosteroids is not, a trivial thing. The question could be, how often do you make a treatment decision with high levels of uncertainty? And the second would be, do you think or do you have any experience about how it can change with the use of cryobiopsy?
Is Dr. Dubinsky still here? Because I suppose your question would be for her.
For you, because we know what Diana thinks is for you. Do you have any experience? In your center, because you work with, this is a rare disease, but you work with rare diseases. So
yeah, so we very often do the diagnosis with just one systemic manifestations, but it has to be a typical one. So if a patient has a typical extrapulmonary manifestations, and when I say extrapulmonary, it's also other than just ENT manifestation, like mononeuropathy or cardiac manifestation, things like that. That would be highly sufficient for me to consider it a definite diagnosis. You don't really need a biopsy. And you don't need the anchors because in pulmonology, we usually see patients without anchors. That's for the question for the criteria. And then for the cryobiopsy, I have very little experience of biopsies at all in patients with EGPA because we usually don't biopsy patients with eosinophilic pneumonia. If we do a BAL, as you know, we have the diagnosis of eosinophilic pneumonia, and that's sufficient for the lung part. And then for the rest, we would do an electromyography. We would, do cardiac investigations and so forth. But to biopsy the lung, I think should be really exceptional. I know I've shown 3 cases with the lung biopsy, but there were 3 cases out of many, many, many who didn't have a biopsy. And these 3 patients had a good cause to have a biopsy. They had a special disease that would not fit really with eosinophilic pneumonia, and they had no systemic manifestations. Otherwise, we would have made the diagnosis of EGPA without a lung biopsy. So my advice would be to not to biopsy the lung, to make sure you do the BL early enough and before treatment, and to carefully look for organ manifestation, especially the heart, because it can be silent manifestation. And a good internal medicine examination very often reveals there are signs that initially the pulmonologist didn't see. So we need the help of the rheumatologist or the internal medicine doctor to help us make sure there is or there is not organ manifestations outside of the lung.
Yeah, in fact, the rheumatologists are some of the few specialists that still do the physical examination of the patients. With the pneumologists, especially during the pandemic, are not the best for that. So we could continue on the whole afternoon, but we know it's a Friday night for Dr. Cottin, and we don't want to be abusive. So we are going to end with this session of question and answers. And really, thank you very much. It was a very, very informative and comprehensive lecture. It's a topic that, as you say, it's a rare disease, but any pulmonologist can see a case a year. And especially in a country where, unfortunately, we have a high prevalence of tuberculosis, which has many times a very similar radiological pattern, and giving steroids is not a very good idea. So really, thank you very, very much. Jonathan.
Un placer.